lesions are more common, we see it more, and interventional radiology plays a curative as well as a palliative role in addition to other techniques such as surgery, radiation, and oncological therapies. The approach to malignant bone tumors depends on how you organize, how you think, what the patient wants and what he needs, not what you can do. This was a scheme postulated by Professor Afshin Ganji back in 2012, and we tried to add to this technique my approach, or how I approach such lesions in bone metastasis. So I divided the treatment into three main categories, which is the adjuvant treatment, preoperative devascularization or peri-radiotherapy consolidation, curative intent, which is definitely thermal ablation plus or minus the need for consolidation, and the palliative effect, which is divided into do you need to consolidate the bone tumor or stabilize the bone tumor, or do you not need? That includes cementoplasty and osteosynthesis plus or minus ablation, and no need for consolidation, which is a palliative effect, which is simply thermal ablation or embolization. I'll talk about each branch alone. First is the adjuvant, which is a preoperative embolization or devascularization. We usually embolize vascular bone tumors, most commonly HCCs, RCCs, or thyroid cancers metastatic to bone. The most common sites are the pelvis, spine, and the proximal femur. We go selectively into the branches, exactly like the ruptured ones, but we do it electively. We embolize the branches until it's completely devascularized, and then we can send them to surgery within 24 to 48 hours. Usually, we use PVA unless there are some surprises. This was a case in the femur. This is preoperative and after, from the superficial femoral and the profunda. This was a case in the femoral neck, showing extreme vascularity. She was scanned for a hip prosthesis, and this is before and after embolization, showing complete devascularization. She successfully did the surgery. She was home the next day. The peri-radiotherapy consolidation, peri meaning before or after the radiotherapy. And it depends on multiple factors. Again, we do it on an MDT basis, where there is a high risk of pathological fracture in predominantly lytic lesions where the bone is destructed. We usually do cementoplasty first, and then we send them for radiotherapy so the patient can tolerate the radiotherapy and live a better quality of life. However, this is a case, bronchogenic metastatic to D12, and this is the corresponding bone scan, and this is after, this is after consolidation. We fill the vertebrae with cement and send the patient for radiotherapy. However, and especially when SBRT is considered, SBRT has a risk of 15 to 40% of vertebral compression fractures after SBRT, so we usually go for vertebroplasty before. However, in some cases where it's a single metastatic lesion and the intent is curative by SBRT, we usually do our consolidation after to avoid the theoretical or potential risk of displacing tumor cells inside the circulation. Also, when there is an epidural extension, we usually wait for cementoplasty after the epidural extension has been managed and do our vertebroplasty. This is a case of the following radiotherapy. He had prostate cancer, he had severe pain, pathological fractures. We went in bilateral sacral approach, we did a cementoplasty, and the patient did well. The IR approach to bone metastasis, again, the curative intent is definitely by ablation. There are many modes of ablation currently in the market. However, patient selection is very important. We have to select a patient with an oligometastatic disease, oligorecurrent or oligoprogressive disease, 3 or 5 potentially treatable metastases. We usually prefer going under 3 centimeters, although some literature goes to up to 5, and the safety margin that is not compromising the surrounding neurostructures, or try to protect the surrounding neurostructures. The most common devices available is the radiofrequency ablation, which is present in Egypt. The cryoablation, unfortunately, is not there. The survival rate is almost equal between them. So there are some differences. Cryoablation causes less pain, however, it's more expensive. And the microwave ablation, unfortunately, there's no large-scale series, unlike the radiofrequency and cryo. And the MR-guided HIFU is what we call a new tool or new kid on the block. Again, there are no large series about MR-guided HIFU in the curative intent. However, when we approach a lesion for a curative intent in a weight-bearing zone, such as the acetabulum, such as the iliac bone, or the spine, we usually need to perform a consolidation after, and usually this is via placing some cement. This is a case which fortunately had 2 lesions from renal cell carcinoma, one in the rib and another one in the iliac bone. We went to perform radiofrequency ablation for both, and then we injected cement in the iliac bone. This is the baseline, showing a lesion, and then it regressed after follow-up for 4 months. And this is the other lesion being filled by cement with the sclerotic margin, denoting good ablation or control. The palliative effect is more complex, which is usually palliation for the pain or palliation for the stabilization, preventing fractures or treating fractures, managing fractures, or avoiding local tumor progression, where if it progresses, it will compromise other structures in the surrounding area. We usually go for, in the spine, we usually adopt the spine instability neoplastic score or SIN score, which depends on the location, the pain extent, the bone lesion, whether lytic or mixed or sclerotic, spine alignment, percentage of vertebral collapse, and the posterolateral or neural element involvement. We give them a score. From 0 to 6 is a stable lesion, from 7 to 12 indeterminate, possibly impending instability, and 13 to 18 the most instability. Again, with our colleagues in the spine surgery department, we select the patients for which treatment is better, depending on how much the patient can tolerate and how much will he benefit. Again, there are scores for the hip joint and scores for the long bones. I'm sure all the radiologists know them. The mainstay of consolidation is cementoplasty, especially in the weight areas where the compression force is highest. The compression from up to down cranial cord, the compression force. Okay? And the pain control therapy is that it reinforces the bone. Occasionally it produces heat, so it denerves the heat, causes denervation of the periosteum, so the pain is less, and it decreases the load on the normal bone, again, which causes the pain to be less and the load on the normal bone to be less. The classical is vertebroplasty. This patient had multiple myeloma, 3 levels, SIN score of 10, 10, and 11. So we simply performed a 3-level vertebroplasty with good filling of the vertebral bodies and good control of pain. Another patient, which is more a level up higher, which a patient had a C2 osteolytic lesion, here available on CT. Again, she had a score of pain score of 9 with a SIN score of 10. We went with the help of our ENT colleagues. We got a mouth gag and went directly transoral and injected cement to fill the C2 vertebral body with good outcome. As regarding the pelvis, the pelvis is the more complex structure. Again, if you have a corticated lesion or the bone around the lesion is intact, a simple injection of cement to fill the defect and reduce the pain again is feasible and acceptable. Fill as much as you can and extend the bone, extend the cement into normal bone to anchor your cement. However, if the lesion has cortical disruption or there are pathological fractures, percutaneous osteotensis or screw fixation is the way to go in this area, provided the patient can tolerate it. And again, we can use only spinal anesthesia or sedation and good local anesthesia if the time is short. The advantage of screws, they provide support in a multi-dimensional or stressful situations, such as torque and tension, rotational forces and tensional forces, in addition to the complement, the cement, which supplies in compression force. We usually go for adding screws if there is significant fracture already present or there is significant cortical destruction along the major buttress of the pelvis. This is a patient who had metastatic bladder carcinoma. He had radiotherapy. Again, he had a fracture and recurrence. So we decided that the patient was unfit for surgery. He was comorbid. He had protrusa stabili. The only solution was total hip replacement, and the other metastatic sites, the patient was unable to walk. So using the cone beam CT, we do a CT on the table. We plan the areas perpendicular to the fracture. We put our markers and go to the needle in a bull's-eye position or using needle guidance and place our screws along the tracks through very small holes. Again, we threaded the screw in the iliopubic and the supraacetabular region and then inject some cement to stabilize the screws. This is the final result, which was fair to the patient. This is another patient. She did not have a fracture, metastatic renal cell carcinoma. She had surgery on her tibia. However, it was very bloody, so the surgeon refused to operate on the pelvis. So we went for an embolization. This is the lesion. We went for embolization, again followed by cone beam CT. We placed our K-wires, threaded our screws, and filled the acetabulum using cement. And she had, these are only the scars we use. Again, very good outcome. The patient had good tolerance to pain. The pain did not completely disappear, but she reduced her analgesics requirements for narcotics into off-the-counter analgesics available in any pharmacy. Our last palliative is when we do not need consolidation. And there are two arms for this one. There is whether if the tumor is progressing, it will compress major neurostructures or infiltrate other structures, or there's pain. And the pain usually is at the site of the tumor-bone contact, not centrally within the tumor, but rather at the bone-tumor contact. Again, the available palliative thermal ablations are the radiofrequency, cryo, microwave ablation, and MR-guided HIFU. This is a patient who had a metastatic lesion to the sacrum, very vascular. First, we did some embolization to reduce the vascularity and reduce the power. We planned, very important to plan. This is an elective case. You can plan and discuss. And then we went on our planned sites and tried to ablate the bone tumor interface. This is the after. We can find that the areas along the bone tumor interface are ablated, and he had a quite adequate pain control. Another thing is simple transarterial embolization, not for preoperative, but rather for control of pain. This reduces the blood supply to the tumor. Tumor may shrink, it may cause sclerosis, and reduce the tension on the periosteum or bone. This is a metastatic RCC to the rib. We went for embolization from multiple intercostal vessels, and the patient had good pain control, no need for further management. Again, we have to mix the tools. We can use ablation, we can use embolization, we can use both, we can use embolization and etc. But however, sometimes when there is significant cortical destruction and you need to fill the lesion with cement or control it, you can use the ablation to create a simple cavity so that the cement will not seep or leak into the surrounding structures. This was a patient who had metastatic, again, RCC to the pubic bone. We went for a retrograde transpubic approach. We did some air injection to isolate the epidendal nerve, and then we went retrograde for a DAB or RF, just a simple RF that we do not intend to treat, but to create a cavity to avoid the leak. And we filled the cavity with cement, and this is the final result. He had acceptable pain control. I would largely use cement screws nowadays, but this was an early case. The future directions involve dedicated ablation device, especially to the spine, because the morphology and the anatomy of the spine is different than the bones. Some needles form an ablation zone between the two poles of the ablation device. Other lesions have curved ablation devices where they can conform to the axis of the vertebral body, producing a better and more anticipated ablation zone. And the spinal hardware, where they try to uplift the vertebral body, reduce the kyphoplasty effect. This is a spine jack. It's not available again in Egypt. Some other devices are available, and it helps. There are some studies ongoing about its value in metastatic bone lesions in the spine. They're used a lot in the osteoporotic lesions, but this and metastatic lesions are still under study. Another effect is the electrochemotherapy, which is reversible electroporation, where you go into the lesion, electric current, it disrupts the cell membrane temporarily, where you inject your chemotherapy, so it goes selectively into the tumor cells, allowing it to heal. And this is of the literature. Again, it's not available as of, unfortunately, in Egypt, but this is a very new kid on the block, and it has some promising results. Hopefully, we'll know soon about the outcomes. So again, our approaches to bone metastasis include adjuvant, curative, and palliative. Take your time to plan. Do what the patient needs and not what you can do. And thank you. This concludes the first portion of the session, which is about bone tumors, benign bone tumors, malignant bone tumors, and